The axillary approach anesthetizes the brachial plexus at the level of its four main terminal branches: musculocutaneous, median, radial, and ulnar nerves. It is an excellent choice for anesthesia and postoperative analgesia for surgeries below the elbow, forearm and hand surgery. Axillary block is a brachial plexus block conducted at the level of the terminal nerves. The axillary artery is the most important landmark, and the nerves maintain a predictable orientation relative to the artery. This is a cross-section of the arm high in the axilla, where axillary block is usually performed. The nerves seen in yellow are arranged in four quadrants relative to the axillary artery. The median nerve lies in the upper superficial quadrant, while the musculocutaneous nerve lies in the upper deep quadrant. Both the median and musculocutaneous nerves can be accessed from the same puncture site just above the axillary artery, as seen by red arrows. The ulnar nerve lies in the lower superficial quadrant, while the radial nerve lies in the lower deep quadrant. Both the ulnar and radial nerves can be accessed from the same puncture site just below the axillary artery, as seen by the blue arrows. Position the patient supine with the head facing away from the side to be blocked. Abduct the arm at the shoulder to 90 degrees and flex the elbow at 90 degrees and rest it comfortably. With a pen, mark the important landmarks: the axillary artery high in the axilla. Mark a cross just above the artery. This is the entry point for blocking both the median and the musculocutaneous nerves. Mark another cross just below the artery. This is the entry point for blocking the ulnar and the radial nerves. Don't abduct the shoulder joint by more than 90 degrees, because it makes palpation of the axillary artery pulse difficult and increases the risk of damage of the nerves during needle movement. After adequate draping, perform skin sterilization using povidone iodine or chlorhexidine. Raise a skin wheel using 1% lidocaine at the points of entry, just above and below the axillary artery, using a 27 gauge needle. Insert the needle just below the axillary artery at the point previously marked. Insert the needle at a shallow angle of around 30 degrees because the ulnar nerve lies superficially. Ulnar nerve twitches consist of finger flexion, thumb opposition, or ulnar deviation of the hand. Start with a current of 1 to 1.5 mA, then reduce the current gradually until appreciable twitches are obtained between 0.2 to 0.5 mA. At this point, 7 to 10 mL of local anesthetic are injected. Insert the needle more and at an increased angle of 45 degrees. Radial nerve stimulation leads to wrist and finger extension. Start at a current of 1 to 1.5 mA, then reduce the current gradually until appreciable twitches are obtained at a current of 0.2 to 0.5 milliampere. At this point, inject 10 mL of local anesthetic. During searching for the radial nerve, triceps twitches may be encountered. Although innervated by radial nerve, triceps twitches may represent direct stimulation of the muscle, and radial nerve block may then fail. Always inject only when wrist or finger extension are obtained. Insert the needle just above the axillary artery at the point previously marked. Insert at a superficial angle of around 30 degrees. Medial nerve twitches consist of forearm pronation and wrist and finger flexion. Inject 10 mL of local anesthetic. The needle is advanced deeper at an increased angle of around 45 degrees and in a superior direction until biceps twitches are obtained, signifying close proximity to the musculocutaneous nerve. When appreciable twitches are still present at a current of 0.2 to 0.5 milliampere, inject 7 to 10 mL of local anesthetic. Evidence suggests that a 3-injection technique, in which the ulnar nerve is not located, provides a similar efficacy to the 4-injection technique. So, a triple stimulation technique seeking the median, musculocutaneous, and radial nerves should also be sufficient. It is considered the safest approach with brachial plexus block because of the distance of this block from neuraxial structures and the lung. Possible complications include systemic local anesthetic toxicity, so aspirate carefully before injection, vascular puncture and hematoma formation, peripheral nerve injury, and infection.